Welcome to the Healthcare Innovation Podcast. My name is Dmitry Petrov. I'm an assistant professor of neurosurgery at the University of Pennsylvania. And today I have with me Corey Feldman. Corey is the VP of Business Development for EmaCare. Corey, thank you so much for taking the time to join us. How are you doing?
Doing well, thanks. Thank you for having me.
So to get it out of the way, I know you're in New York City. How's the atmosphere down there?
It is really quiet, to be honest. I've never seen the city this quiet before. You walk the streets at 7 p.m. on Saturday and it feels like it's 3 o'clock in the morning. I mean, I think at the least people are beginning to take this seriously, which is good. We're hoping that it's not too late to really make an impact and flatten the curve, so to speak.
And so right now it is evening time on the 22nd of March. And just now, New York State has instated essentially a shelter in place, or New York on hold, I think they're calling it. And so this is becoming very, very serious. And so what we'll be talking about today is, in this time where resources are becoming more and more scarce and testing is relegated to only those who are in the healthcare fields so they can continue working or be quarantined, and those who are at the highest risk, the question becomes, how do we identify those people that are at the highest risk for having not only infection with COVID-19, but also to have the most difficult clinical course and the worst outcomes? And that's where you come in a very innovative way. Can you speak to that a little bit?
Yeah, sure. Really, one of the many problems with this pandemic is that it provides a perfect storm, so to speak. You have, on the one hand, a tremendous increase in demand for provider services. You have panic that creates a false sense of need for provider services. And on the supply side, you have a diminished number of providers who also can become afflicted with this virus and then fall out of commission. And so you have these kind of two things that, if you had one on its own, it would be bad. And having both together obviously creates serious issues. And so what became clear early on to us, and I think to most folks in healthcare, was that there was a need to triage, meaning if before the average primary care physician sees a panel of, I think, 2,300 patients in the US, you can't have, half of those patients who are concerned calling their provider directly. You need to have a way to kind of triage and make sure that those that are ultimately contacting or visiting a provider are truly those that need services. So what we did effectively was transform our chronic care management platform into a COVID-19 discovery platform. So what that means in practice is that we have deployed our software with 3 care management agencies who employ each around 3,000 or 4,000 care managers, home health aides in the field. And the Department of Health issued a statement last week that care management agencies are required to check in daily with their aides to ensure that they are not exhibiting symptoms of COVID-19, and if they are, to report it so that they're not infecting the patients that they're going to visit. So what we've effectively done is created a clinical pathway that prompts the aides each day with questions about their own condition and the condition of the patients that they're visiting, to ensure that they're not experiencing any of the symptoms that I'm sure we're all familiar with: shortness of breath, fever, dry cough, etc. So it's a means of, yeah.
So just to jump in, so what essentially you're doing is you're monitoring the health of both the aides that are going out to see these patients, as well as the health of the patients themselves, in order to minimize interactions with sick individuals. And that is all with prompting through an app. So if I'm an aide going out to see a number of patients today who are chronically ill at the highest risk, I will have to go through a questionnaire on your app to talk about how I'm feeling. And then at the end of the day, I'll also have to do the same thing for all of my patients. And that gets fed through some sort of AI algorithm to flash warnings at the care agency side to say, like, hey, aide Dmitry is high risk for being infected, or patients 7, 9, and 22 are at high risk for being infected. And then that helps the physicians effectively triage. Is that about right?
Yeah, we actually even inserted a layer in between the home health aide and the physician. So what happens if you answer a question in a way that indicates a potential contraction of the virus is we have nurses at home base manning this dashboard, which most of them are actually doing from home now. And when you answer that question and say, yeah, I have experienced a fever, it flashes an alert on the dashboard of that nurse, who then plays quarterback. So that nurse is going to call you, and he or she's going to ask you how you're doing and make a judgment call on where the best place to send you is. Is it self-quarantine, depending on your comorbidities and your risk? Is it going to one of the stations where you can drive up and be tested, right? So there's a lot of different kind of, there are different avenues that he or she can send you down, and we leave it up to the nurse to kind of dictate whether or not you actually move on to that next level, which is interfacing with a provider.
So without something like this, it would just all be human interaction. It will be up to the aide to report symptoms voluntarily and to recognize the symptoms in their patients. And if any one of those links gets knocked out, if an aide is out, if a nurse is out, if anything like that is out, then sort of the whole tree of care breaks down. But now that you have this in place, it's sort of a backstop to ensure that we're not missing infections, we're not contributing to the spread, as well as identifying those patients that are at the highest risk. Because I think you mentioned that you're dealing with very, very high risk patients with this kind of essentially telemanagement. Is that right?
Yeah, I mean, in essence, we started as a platform for chronic care management, right? Medicare launched chronic care management and remote patient monitoring 2015, basically with the idea that if you are checking in with that highest risk group on a monthly basis for at least 20 minutes, you improve outcomes and you lower costs. And so that was kind of the birth of this EmaCare platform as a means of checking in on patients with things like chronic heart failure, COPD, just checking for exacerbations and being able to intervene in real time when those things sort of pop up, as opposed to waiting 3 months between appointments, at which point it may already be too late. So the pivot here was just to add a new clinical pathway for COVID-19 and prompting those same questions that could identify an exacerbation. And it's an accountability tool as well, right? It's one thing to say, well, I'm feeling a little bit off, but I'm not sure, right? But if you're forced to answer these questions each day and put it in writing, there's some level of accountability that comes with that as well.
Mm-hmm. So is there any talk about moving this sort of self-monitoring tool to healthcare providers in a hospital setting, to other patient populations, just to maintain this net and to keep people honest with themselves about how they're feeling and whether they should seek care or not?
Yeah, we've been in discussions with several government agencies and integrated delivery networks, because we pivoted fairly quickly to make this applicable to the pandemic. We want to test it out first with these care management agencies and work out the kinks that come with a pivot that happens this quickly. And thereafter, once we've been able to kind of solidify our processes from there, we will certainly reach out to these agencies and see if there aren't more folks we can help at a greater scale.
Very interesting. So in essence, it's a fairly innovative way to manage this, because you have a population of patients that are at high risk, but a diminishing set of resources to monitor them. And this seems like a very interesting way of going about it. Well, Corey, thank you for your time. I hope you're hanging in there. Any final thoughts before we conclude?
Stay at home.
Yeah.
Except for you.
That's certainly a good one. Yeah, I have to.
The rest of
I don't get to stay home, but very good. Well, thank you for your time, Corey. Be safe.
Dimitri, thank you.